Oh yes, you're going to stick? Okay. Okay, I think that's good, yeah. And by the way, they only choose female. They are filming you, so your face is quite good. So they will turn the camera.
Did you understand?
I didn't. So people are coming in, that's good.
Rüdiger Krech.
Yeah.
He's German.
German.
Rüdiger Krech.
Rüdiger.
Dear colleagues, welcome to our plenary session on the transformational potential of health promotion. It's a pleasure to have you here in Berlin, and I hope you have a good time and enjoy this European Public Health Conference here in Berlin. Over the past decades in Europe, the nature of disease burden has shifted from more communicable and acute chronic diseases, such as cardiovascular diseases and so on, into more preventable diseases. We all know that chronic diseases can be difficult or even impossible to cure, and that they will become more and more costly. Our health service systems, with its curative approach, are not suited for this chronic epidemic that will cause so many costs, and that the room of maneuver in all political fields will be affected. There is an urgent need to seriously direct our attention to health promotion and disease prevention, and to invest more in health than illness for all relevant actors. Health promotion has the potential to transform our health services. This plenary session will provide examples of different ways in which health promoting approaches can reorient health services, strengthen health promoting and community-oriented primary care, and prevent chronic diseases. My name is Martin Dietrich. I'm acting director of the Federal Center for Health Education in Germany, in Cologne, and I am president of EuroHealthNet. And here's Caroline Costongs, director of EuroHealthNet. Together we chair this plenary session.
Many thanks, Martin. It's a pleasure to co-chair the session with you. I find it a very important session because one of our challenges for the future is to make sure that our health systems are sustainable, affordable, and accessible to everyone. And we know that we need to boost health promotion and disease prevention and develop our capacities for that, because that's key to sustainable health systems. We also know that we need to work more closer together with social services, with other services in communities to do that. I see already that at national government levels, they are keen to boost health promotion and disease prevention. And they are looking to us how that can be done. And we need to be there and to give our answers and evidence how we think we should take it further. And that is what we will be doing in this session. We have some excellent panelists here, and they all give their perspectives and their vision on how they think we can boost prevention and promotion and develop and reorient our health systems so that it benefits everyone and reduce health inequalities at the same time. We will start actually with Rüdiger Krech. We will show a video of him. And Rüdiger Krech is the Health Promotion Director of the World Health Organization in Geneva. And he will share his vision for health promotion with you in a video. So if we can have the video of Rüdiger Krech.
Dear colleagues, I'm really sorry that I can't be with you in person today, but here I am with this video. In Europe, 9 out of 10 deaths and almost 87% of the deaths in the EU in 2017 are the result of non-communicable diseases, of which approximately 61% can be attributed to the risk factors of tobacco and alcohol use, physical inactivity, and unhealthy diets. A fifth important risk factor is that 99% of the global population breathe air that exceeds the WHO guideline limits and contains high level of pollutants. In these data, there is a huge potential for global health, and indeed some very positive news. If we do our job in public health well, by addressing these 5 risk factors for health, we can free up 60% of the burden to the health systems. This is decisive, as any health system will break down would we continue and not drastically reorient our work to prioritize health promotion and prevention, as we in addition face the demographic trends of aging societies in which people will require more care at the end of their lives. Through rigorous work on these risk factors, we will contribute to the resilience of health systems as we can unlock resources for better care. How do we best address these risk factors? We have learned that siloed single interventions are not effective. In contrast, we know that multi-level intervention packages that address the underlying conditions, address the commercial interests, as well as the political and societal determinants, work very well. The work on tobacco control has learned us some lessons, how such packages must look like. We need to understand and counteract industry interference, empower communities and countries in regulating and using their fiscal powers, assist governments in multi-sectoral approaches, and joint up government. We need sound data to monitor and assess the situation in order to prioritize and align our strategies to the evolving situations. We need to help the banking sector to disengage from unhealthy products, commodities, and services, and to move into more healthy ones. Finally, we need to assist people to make healthier choices. There is thus a technical part in addressing the main risk factors to health, for which I can say, we know what works. We know the do's and don'ts. But then there is a political side to this as well. Too often in our societies, profits are individualized and costs are socialized. This puts an unfair burden on the health systems and on taxpayers. How much would a can of Coke cost if healthcare costs due to obesity, cardiovascular and dental care, costs for absenteeism and early deaths would be factored in? How much would a hamburger cost? Some countries have done the calculation for a pack of cigarettes, which should be at 23 euros. Health promotion can be a driver in a fundamental review of how societies can be redesigned to address both sides of the same coin. How to prevent risks and how to create a world where all people enjoy healthy lives and well-being, living in a healthy, safe and supportive environment as members of an inclusive society. How? Let me give you an example. The tobacco industry wants to make us believe that e-cigarettes would be a good cessation device. This could not be further away from the truth, as in reality, the tobacco industry uses e-cigarettes to keep people addicted. Tobacco lobbyists are well connected with government representatives all over the world, but so are representatives from pharma, social media, and sickness funds. There are 2 nicotine replacement therapies on WHO's essential medicines lists, which means that they should be available in every pharmacy in the world. There are social media companies who want to do something about the increasing fake news, dis- and misinformation in the net. There are sickness funds who see a huge advantage in prevention. We established, therefore, a WHO consortium for tobacco cessation with those pharma producing the nicotine replacement therapies on the essential medicines list, Google, Precold, and some sickness funds to advocate for tobacco cessation. Each business is using its role and function to best promote this. Together, this is a strong alliance against the tobacco industry. Colleagues, I bring this up as we need to get to a next level in understanding commercial interests and determinants. Before, it was the public health community against tobacco industry. Today, it is partnering with businesses, building a healthier future. Dear colleagues, health is a compass for development and a barometer for a nation well-being. As money makes the world go round, we need to address main financial flows. To create a world that is better preventing a new pandemic, to disrupt the world, the risks and their conditions need to be addressed. To develop a healthy economy, we can and must be supporting the industry and enable them to make the healthy choice. I thank you.
Yeah, thank you very much, Rüdiger. He's not present here. We appreciate how he has pointed out the WHO position of health promotion, disease prevention, and what measures are already undertaken. We have heard some numbers and how risk factors are correlated to premature death, and that there is a huge potential for public health. And we have heard what is recommended and what examples do exist that show what works, especially in the case of tobacco prevention. So we now will open the discussion. Before that, we have a few presentations and a few statements. And we have some very interesting speakers with us. And so there are opportunities of reorienting health services and things we do know about the do's and don'ts in health promotion, disease prevention. And these do's and don'ts are often very closely related to the health behavior, which in turn may depend on how the healthcare systems work. Therefore, and for further insights, we have Susan Michie with us. She is Professor of Health Psychology, University College of London, and Director of the UCL Centre for Behaviour Change. Welcome, Susan.
Thank you. Good. Can I? Yes, just click move it on. Next. Yeah. Lovely. Thank you very much. Hello. In my 4 minutes, I have been asked to address how can healthcare systems be more sensitive to behavioural and cultural factors and act on them. So I want to share with you some principles and basically some headlines, which I think actually elaborate one dimension of what we've just heard. So I don't have to tell this audience, but a starting point is for many chronic diseases and indeed infectious diseases, behaviour is both at the heart of leading to them, but also preventing them. And whose behaviours are we talking about here? Now, often people think in terms of patients or the public, but we also need to think about the systems in which patients and the public are embedded. So families, employers and managers, providers, professionals, planners, policymakers, local, national government, etc., etc. We've heard about the commercial determinants of health, whole numbers of people involved there whose behaviour we urgently need to change. Everybody's familiar with this, making the very important basic point that when we're thinking about enabling people to change their behaviours, we need to think about the individual lifestyle factors, the social and community factors, all the different cultural, broader social contexts, and finally the political and economic systems within which people live. And we need to think not just in terms of layers, but in terms of systems. How individuals, how groups, how organisations, how different levers are interconnected if we're really to work effectively in bringing about change. And what settings are we talking about? People have talked about health services, have talked about health systems. I suppose here what I want to say is I think our health system is the whole of society. When we think about the settings in which we engage people to prevent ill health, we're thinking about community outreach, going to where people are rather than waiting for people to come to us. So people's leisure settings, their workplaces, using transport, shops, wherever people are. Now, how do we think about behaviour? And I want to share with you probably the simplest, but also the most comprehensive model of behaviour. And this is for any behaviour to occur, and just think about yourselves. You have to have three things. You have to have capability, the knowledge and skills, the psychological capability, also the physical capability. But that's not enough, as we all know. You might know that you should be doing something, you don't do it. Why not? Maybe you lack the motivation. Both the sort of top-down decision-making choices, but also the bottom-up, our habits, our emotions, our drives. People can have the capability and the motivation, but still behaviours won't occur unless there's the right opportunity there, the enabling social and physical environment that people are in. And as you can see, these all form part of a system. These can all be many, many times more elaborated, but this is a top-level, simplest idea. And if people want to find out more about it, the URL right at the bottom is to an open access guide to using this to understand and enable change in behaviours at all levels. So if we want to try and think about what needs to change for every behaviour and every group that needs to be changed in order to solve a problem, there are many questions you can ask. I've just put illustrative ones here. Do people have the knowledge and or skills? Do they have the time and or resources? Motivation. Do they think it's important? Do they feel engaged and valued in the process? Do they need to change entrenched habits? So really, when one's trying to understand a behaviour in its context, which one always needs to think about the context, these are the kind of things to think about. And too often, people just don't think about one or more of capability, opportunity, and motivation. So think combi to remember this. Just want to finish saying something about being behaviourally and culturally sensitive. The importance of recognising diversity of communities, but also groups within communities and individuals within groups. You know, it's not enough just to think about young people or people from ethnic minorities or people from disadvantaged, impoverished backgrounds. One needs to think about how all these intersect with each other. And so important not to make assumptions about the behaviours, but also the influences on behaviours of the many different groups that we're dealing with. Secondly, learn about the beliefs, the practices, and the contexts that influence health-related behaviours. And I would say on that last one, really it's so important. I was advising the UK government on COVID over the last couple of years, and the number of times that this wasn't done, assumptions were made. And another important principle, consult with and engage communities in their settings on their terms. Why should one do this? Well, strategies are likely to be much more effective if one actually is understanding the real life, the real world situation of people. And also, if one's doing it in a consultative, engaged way, there's going to be much more buy-in to whatever strategies are developed at the end. I know these sound very basic and straightforward and common sense, and all of you are probably sitting there thinking, yes, of course. But ensuring that all of these things are absolutely embedded in all of public health practice is so important and is often not done. And finally, co-creating, or sometimes people call it co-producing, policies and measures with the communities that they're aimed at. And this means really jointly thinking about what are the key ideas here, what are the key values that are driving people. Terminology, so important. What media do different groups use? Again, these will vary, and having worked with government policymakers over many decades, I don't know how many times I've witnessed people getting it so badly wrong by only looking at literature or only consulting with colleagues. And finally, trusted sources. Who is it that people are listening to and trusting? Thank you.
Thanks a lot, Susan, for your great presentation and insights. I think the COM-B model is so illustrative and so important for health professionals and policymakers to take on board. We know that the WHO is advising governments to set up behavioral and cultural insights unit, and I'm hoping that they will be using your model and all your insights about linking directly to the community, which is really very important. So thanks a lot for that. And I think that bridges also very nicely to our second speaker, Professor Jan de Maeseneer from the Department of Public Health and Primary Care of the Ghent University, and also the chair of the EU expert panel on effective ways of investing in health. And you told me, Jan, that you started 40 years ago in health promotion, actually, and then moved on to be a GP in Ghent. And my question to you is, so in your opinion, why do you think that health promotion and disease prevention is not yet sufficiently sort of embedded into primary care? So I'm looking forward to your presentation.
Thank you very much to give me the opportunity to speak from my background as a family physician. And I think that in primary care and in family medicine, health promotion is extremely important. And with the expert panel on effective ways of investing in health, in 2019, before COVID, we already made an opinion on options to foster health promotion, health promoting health systems. And we made very clear there that health promotion within primary care should be strengthened because we wanted to make clear that in order to improve health literacy, we should create health literate primary care organizations and focus very much on strengthening and empowering the people in the community. That we can do not only at the individual level when we talk about strengthening positions of patients in communication, focusing on shared decision making, but also in the broader context of the community. And we will come back to strategies like community-oriented primary care that are excellent in order to put a health promotion in practice. Why is primary care an important opportunity for health promotion? I think because, generally speaking, the people trust primary care teams. They trust their physicians, their nurses, their social workers. And this trust is, of course, based on the curative work we do on a daily basis. And I think that you can take advantage of that trust also to use primary health care as the place where the messages about the health promotion can be, in a very effective way, put forward. Now, the big challenge, it's already said at the introduction nowadays, is that we are faced with multimorbidity. And I think that multimorbidity invites us to shift fundamentally our approach from the traditional vertical disease-focused, siloed, lifestyle-oriented approaches, focusing on individuals, shifting towards an integrated, horizontal, goal-oriented approach, looking at the achievement of the life goals of the individual, the patient, and addressing the living conditions and socioeconomic and ecological determinants of health and well-being in the communities. And I think every dimension of this shift is important, and nowadays we are facing efforts that we are putting into practice in order to make that shift happen. And more we implement strategies, and community-oriented primary care as a strategy is not something new. It has been developed in the 40s in the previous century in South Africa by Sidney and Emily Clark. But it starts from looking at your community. What are the problems in this community? Making a kind of community diagnosis, putting all the information from different sources together, and then involving the community in formulating an action plan for intervention with, of course, appropriate monitoring and follow-up. And this circle, I think, we practice it during the 40 years that I worked in the Community Health Center in Leiden very often, in order to, for instance, make the community more safe in terms of traffic insecurity, to improve the physical conditioning of the youngsters by emphasizing the importance of green spaces, to improve access for dental care by putting forward new facilities in the community and creating also a new profession, being the oral health hygienist in the community. But also at a broader level, we can use that. We had the experience with COVID that we had planned a prioritization of the vulnerable people with chronic conditions, and we managed to do that using data from two sources, a decentral source, which were the health records of the general practitioners, and a central source, which were the health data set of the insurers. And we put that together, and there was original contribution in finding 350 people, 50,000 people at risk by the GPs, 600,000 uniquely by the insurance companies, and more than 900,000 that were detected by both. So the strategy was very performant, and 1.8 million people had priority vaccination, both based on the risk factors. And I think that this is an example that you can use this strategy at all levels if you put the appropriate data together. Another thing that we saw was that our high level of vaccination coverage in the region of Flanders, we were always in the top 3 to 5 of Europe in vaccination coverage for COVID, that this was correlated with the percentage of people in a certain area that had a stable relationship with a global medical record, with a general practitioner. So I think that's a strong indication that primary care really plays an important role in motivating people also to comply with activities like vaccination. And of course, we should focus not only at the medical sector, but also emphasize the importance of intersectoral collaboration, looking at health for all policies, bringing primary care, social care, public health services, but also education, work, and other sectors together. Of course, after the COVID, the question is, will the reactive changes in primary care that we have seen during the COVID-19 pandemic lead to structural strengthening of better integrated primary care and public health services, fostering health promotion? I have to say that I see a lot of homeostatic forces nowadays, and they are very strong. going back to the past and not preparing the future. I see it at the level of healthcare professionals that go back to the old habits. I see it at the level of institutions, governments, and global leaders. Just as an example, the Primary Healthcare Performance Initiative has announced that it will stop at the end of this year because the Gates Foundation and World Bank are no more willing to contribute and finance it. I don't think that this is the way forward and that we have to question the choices that are made. Of course, there is also a need for a high investment in health. And of course, during the pandemic at country level, we apparently have invested a lot, but this is not sustainable. We will need new money, and I think that we can be happy that the EU for Health has looked for 5.3 billion euro, and that one of the aims is to strengthen health systems so that they can face epidemics as well as long-term challenges by stimulating disease prevention and health promotion in aging populations. And I think that we need, in order to make our changes stable and sustainable, some important steps. I think we should invest urgently more in integrated interprofessional health records, because they can give us the information in order to orientate our health promotion actions on those things that really matter for the people in the community. We need more integrated interprofessional payment systems in order to bring social care and healthcare together and make professionals to work together, involving also the public in their health promotion activities. And also we have to make changes in organization. Population-oriented approach at the micro level is very important, because there it starts what lives in the local community, what are the factors that are threatening the health of the population. Scaling up to networks of 10,000 people, I think, will be important to make the changes happen. We have to look also at the bigger level to organize it, and we have to define overarching health goals at the macro level. And just to finalize my talk, I think that our health promotion activities should be assessed in order to see to what extent they can improve care at the individual level, and to what extent they can improve care at a population level, how they contribute to realizing more value in the community, how they create added value for the professionals, and last but not least, how they enhance social justice and inclusion in the society. Thank you very much.
Thank you. Thank you very much, Jan, for your insights into what role health promotion plays in primary care, and what the community setting can do for fostering health promotion. So you mentioned health in all policies, and this is a bridge into the political frameworks. And therefore, it's a pleasure for me to introduce Professor Bussemaker. She is chairman of the Dutch Council of Public Health and Society, professor of Science, Policy and Social Impact at Leiden University Medical Center. And Professor Bussemaker, as a former politician from the Netherlands, do you foresee any enthusiasm and progress among national or local policymakers for improving health and well-being as part of health systems and or outside the health sector?
Thank you very much. Yes, as you said, I have a career, an academic career. I'm now at the Leiden University, and there I do research also in disadvantaged neighborhoods to try to fight health disparities. I'm also now the chair of the Advisory Council on Public Health and Society for the Dutch government and parliament. And there I try to also to use my knowledge from academia, but also to use my knowledge as a former politician, former Minister of Education and Science and Deputy Minister of Health, to think about what we can learn from former policies and how we can organize effective policies to fight health disparities. The main question I was asked is how can we use our knowledge and experience in policy to think about improving health and well-being, both within and outside the health sector. And I think the combination of within and outside the health sector is extremely important. Listening also to the former speakers, I think there is a kind of similarity between us in what are the key problems in current health policies. And what I see is that the focus is too often only on single health conditions, such as diabetes or depression, but they often co-occur, especially among disadvantaged populations. So we should more look from an integrated perspective. The focus is also too often on medical treatment, while the cause of the problems often lies outside the health domain, work, debts, living conditions, and so on. And so we often focus too much on downstream factors, focus on the individual level, strongly focusing on lifestyle changes, and neglecting upstream factors such as the political and social conditions that shape health. So I think it's extremely important to think in another way about a more comprehensive view on health conditions and health policies. And it's often mentioned, and Jan referred already to health in all policies. And I agree with health in all policies in the way that we need all the other sectors, not only within the healthcare sector, but also outside the healthcare sector. I often have to think about a phrase which is often used in education: it takes a village to raise a child. In the same level, it also takes a village to fight health disparities. But we should not only ask other sectors what they can contribute to health improvement, we should also think the other way around. What can we do for other sectors? As a former Minister of Education, I know how extremely important it is that health condition can contribute to learning experiences, to learning results. And the same is true, I think, for working conditions, labor productivity. So we have to think in two ways, not only what others can do for health, but also the other way around. And that may strengthen the whole population. So that brings me to the next question, what is needed? And if I look to my own country, the Netherlands, I see a strong focus on prevention. That's good. But prevention, which strongly focuses on smoking, on drinking, on food patterns, obesitas, and I think that's not enough. What we need are more maybe legally defined national public health goals that goes beyond only the lifestyle events. And what I think that we have to think more from communities, we have to think community up. Susan and Jan also refer to that experience, I think. My experience in the neighborhoods in The Hague where I do my research is that, of course, they want to quit smoking, but it's not their first priority. If they are living in debt, they don't know how to get their children the next day to school with breakfast. We have to think about other solutions. What I think is that on the one hand, we need the legally defined national goals. For example, with a mission to decrease health inequality with 30% in 2040 or 2050. So make that a national responsibility. And at the same time, create room to embrace complexity at the local level. Because lives of many people, especially in disadvantaged neighborhoods, are very complex. And we have to listen to them, what they need, and by starting to work community up, to co-create with the local population, and by strengthening their social networks. To give you one example, in the neighborhood I do research, a lot of people may get entitlement for individual lifestyle program. But they often say, that's not what I want. What they want is to organize a cooking club together and to learn each other how they can make healthy recipes. And there's no opportunity, there's no financial opportunity for this very small proposal to support them. And I think that's something we need. So what we need is also differentiation and coordination and collaboration in financial systems. For example, by creating shared savings between the social sector and the medical sector, or population-based financial entitlements, to accept local differentiation, because we might need national public health goals that are concrete, that are tailor-made, but on the local level we have to listen to local communities, and that also has the consequences of local differentiation. To support more social networks, because if we have strong social networks, there is much more opportunities to help each other, and also to get the motivation and to get the capabilities, as Suzanne was referring to help each other. So the clear goals should be focused on a political level, but it should require support from the public health system, and so we can create a system that is both effective and accountable. Thank you.
Super. Thanks a lot, Jets, for your insights and your comprehensive approach. And indeed, it takes a village to improve health. I like that. And I also like very much that you stress that we need to have legally binding public health goals. I think that will be very effective and definitely an area where we need to further work on. Thanks for that. And now we are going to our fourth and final panelist. And I'm delighted to introduce to you Cristiano Figueiredo. And he's a GP in central Lisbon, and he's also working at the National School of Public Health and the Nova University in Lisbon. Cristiano, we met during the EuroHealthNet country exchange visit earlier this year in Lisbon, and I'm really impressed by your work. So please share with us your approach in the community in Lisbon. The floor is yours.
Thank you, Caroline.
So,
I've been working in primary health care for the last 10 years, 5 years as a specialist family doctor working at the front door of the Portuguese National Health Service in a family health unit in downtown Lisbon, covering about 16,000 patients. Many of them come to my practice with...
Yeah, just the next, the green button, the green.
The green? No?
Yes.
Okay, great. Many of them come to my practice with social, emotional and practical needs to which medicine alone adds little value. Like Abiba, a young pregnant woman from Bangladesh, newly arrived in Portugal, spending most of her time alone while her husband is working. José, an elderly man living in a gentrified traditional neighborhood, spending his days watching TV and complaining of memory loss. Or Maria, a woman in her late 50s, unemployed for 4 years, putting on weight while waiting for retirement, suffering from low mood and self-esteem. These kind of patients present to my consultation room daily, and before social prescribing, he usually had two options: drugs, over-medicalizing known medical needs and neglecting the whole idea of quaternary prevention, or doing nothing, losing an opportunity to support the patient in changing these pathogenic life conditions. Since 2018, these patients have had a better solution to meet social prescribing link worker who has more time to know them, understand what matters to them, and could produce an individual plan to promote their health by referring to local community resources. Like a Portuguese language course for migrants, to join a South Asian pregnancy club to meet fellow women, to participate in several social activities organized by the University of the Third Age, visit a local museum or theater in a group to engage with art and culture, learn how to cook better, attending a healthy cooking workshop or doing some guided gardening at the local botanical garden. Since 2018, many patients have benefited from social prescriptions after attending their primary healthcare center, which dares to act on their social determinants of health by collaborating with the community sector. 5 years ago, I've started the implementation process of social prescribing in my family health unit in downtown Lisbon. To start with, I needed to advocate for the importance of social determinants of health for health outcomes of patients and the performance of health services. Secondly, I needed to recognize that the community sector enables primary care to address those social determinants. Finally, we started to mediate the collaboration between primary health care and community resources through the bridging power of social prescribing. After assembling an implementation team, we started training local doctors, nurses, social workers, and community leaders about social prescribing and social determinants of health. Then we invited them to join us in the co-production of our local social prescribing model, taking part in monthly meetings to decide about our referral criteria, patient pathways, and community solutions. Soon, during those meetings, we are not only mapping existing community resources, but also inspiring the creation of new community-based solutions for social prescribing, supporting the community sector to apply for funding opportunities not available for health services. That's the example of the previously mentioned pregnancy club and healthy cooking workshops. Soon, after we started this social prescribing implementation process, we were changing the clinical pathways of patients, adding to the usual healthcare new upstream person-centered interventions in the community sector. And every time we had the chance to meet health leaders, policymakers, and politicians, we once again advocated for the need to invest in social prescribing as a concrete health promotion action to tackle social determinants of health from a clinical setting. Now, we have a 5-year social prescribing project in Lisbon, deeply aligned with health promotion strategies and actions, and inspiring others to follow our steps. Social prescribing started in the UK in the late 90s at the Bromley Bible Centre in East London. Before it was endorsed and disseminated by the 2019 NHS long-term plan, we started our implementation process in Lisbon. Nova School of Public Health joined our social prescribing initiative to monitor the project and research its impact on patients, health system, and cross-sector collaboration. It is also leading Social Prescribing Portugal, a new national network that aims to advise, train, and empower health services, municipalities, and social organizations to implement and evaluate social prescribing. We have a social prescribing movement going on in Portugal, however, still aside from the Ministry of Health directives. It is still, from the beginning, a bottom-up health innovation. But we are not alone. Many other countries are implementing, testing, and evaluating social prescribing in Europe. Today, social prescribing is a joint action on health promotion, empowering health services to address the social determinants of health, working together with the community sector. This can deeply change how health systems work, but how general practice and family medicine relates to public health. Thank you.
Yes, thank you, Cristiano, for these insights into an innovative approach to become very concrete of how to handle health promotion services in our healthcare system. So I'd like, in the remaining time, to have a few comments from each of you of what the other one has said. So we had behavioral insights into health promotion. We have insights into primary care, and we heard about policy frameworks. And we had a very nice example of functioning social innovation with the social prescribing theme. So, having listened to you, do you agree with each other's perspectives, and how would you like to respond, Cristiano?
So, as a family doctor, I think that primary care really tries to implement in practice health promotion strategies. But sometimes it lacks the resources to do something about the lifestyle of the patients, about the social conditions of the patients. And even though we advocate for them, if we don't have the right link with the community to make a difference, it's really difficult to do health promotion in a meaningful way. Besides that, it's also very important to have the right financing, the right funding for actually the community to can engage with the health sector in addressing the social determinants of health and contribute to health promotion.
Thank you, Cristiano.
Thanks. You mentioned also the shared savings between the health and social sector. Can you elaborate maybe a bit on that as well? And then also feel free to respond.
But let me first say that I see a lot of similarities between our presentations. I think that we all agree that we have to get away from the medical drift, so to say, and that we have to look to the problem behind the problem, and that are very often social problems. That we also all say that we have to engage local communities, whether it's in co-creation or community up, or we both gave the same example of a cooking club, which is a quite simple intervention, or it's no intervention. That maybe that's the difference. It's something that comes from out the population. And what I see that very often there is no money, no subsidies to support this kind of initiatives, because we say it's not medical, it's not already proved somewhere as a good intervention. And at the same time, we see that there is also that if you intervene or if you support this kind of initiatives, you might need to spend less money in the medical domain. So that's what we call the wrong pocket problem. And if you create a kind of shared savings, you might say, okay, we do it together. And then we see what the revenues are, and that's kind of problem for the institutions instead of bringing the problem to the professionals and to the citizens. The city of The Hague has given a very good example of a couple of years ago already, where the health insurance company worked together with the municipalities in fighting debts, because they saw that people with debts had a lot of mental stress. They came to the general practitioner again and again and again, and he or she couldn't solve the problem. And then they did a project with shared savings, and it was very positive because both the insurance company had to spend less money because people did not come to visit the general practitioner that often, and also the problems of debts were now maybe not being solved, but especially, let's say, diminished. And that's an example of shared savings, and I think we need much more of that kind of examples and interventions, especially between the social domain, community care, and the medical sector. Mm-hmm. That's one of the big problems, I think, nowadays. Mm-hmm. But only the financial problem should not be enough. We also need another kind of governance and of leadership. So it's also about where are you accountable for? If we all want to have the kind of small pilots we now have, it has to show accountability for within 1 year, that does not work. We should think in much longer terms.
Thank you very much. Jan, with very interest, I heard about engaging communities in designing interventions for health promotion. This is one thing that was also mentioned as well, that we do not live in health promotion from this one-year project approaches. But nevertheless, what do you think is very important in engaging communities in designing health promotion activities? What are success factors, and what could you recommend for others in learning from examples, for example?
Yeah. Let me first jump into the cooking experience that is very intriguing, because we tried the same in the previous century with a group of very isolated, lonely women that were illiterate. So very difficult conditions, and we said, well, we are going to bring them together and we offer healthy food. And the group said, that's for rabbits, healthy food. We are not going to eat that. We want a full cholesterol menu. And that learns you that you always have to find that small step. And I have to say, we went into a process, and 3 years later, all these ladies had a part-time job. They looked better physically because they had that experience of weekly meeting with the one and the others. And the quality and the healthy indicators of the food increased during the process. And what that means is it's about engaging in process, finding that smaller step that's achievable for them, and also focusing on the important issue of what is the societal value that we create. And in this group, it was, of course, being better integrated in society. So you contribute to social cohesion. And if nowadays I have to sell arguments to politicians to invest in primary care, I don't start with better outcomes for chronic care. I don't start with all kinds of other cost-effective things. I start with, well, if you invest in primary care, these are ways to strengthen social cohesion in society. And that is what you need. Politics need it because that is the condition to build societal programs, to build societal projects with them. And I think that's a very important issue, and it brings us back to the broader context. Of course, there are difficult questions nowadays. I have a little bit doubt about this tendency to give an individual coach to every person in the framework of individual health promotion. Sometimes maybe it's needed, but I have to say this is not the way forward. It's not feasible. It will not reach out to the most vulnerable. But of course, it will not serve the collectivity. And I think that if it is a problem about healthy food, offer the children from 3 to 18 healthy, warm school meals at noon. That will probably do much more and be cost effective than individual coaching of behavior. And it will have spillover effects to the food habits of the family. So I think the project in Amsterdam is a very good example where you see that...
It's The Hague, but it's also in Amsterdam, so it's no problem.
It was The Hague, excuse me. Anyway, in the Netherlands. So that's one thing. And the other thing is what the Scottish did. Well, children have to move from underserved areas. Now let's start the school day with running a mile together. That will probably make more difference than individual coaching. So I'm a little bit worried about what is the position of the collective approach versus the individual approach, and how strategically can we deal with this, because it has huge consequences.
Can I keep that nice question for you, maybe, Susan?
I
think
you have really happy to pick that one up.
Yeah.
I mean, I think that coming out of COVID, we're in even more of a crisis than we were before COVID. We're in a public health crisis. We're in a environmental climate change crisis. And in these situations, what is the best thing to do? I'm also going back to our WHO colleague who talked about commercial determinants of health. I think we absolutely have to think about what's underpinning a lot of these problems. And I think all in different ways. We've talked about it being the system. You know, we can't get away from the fact that the economic and political system within which populations and public health is located is incredibly important. And arguably, if we don't tackle that, we're running up an escalator that's going down all the time. This is a big question, and maybe next year there'll be a whole debate about what should the role of public health be within this bigger picture. What levers does public health have as researchers, as policymakers, as practitioners? But one of the things I think is coming back to, somebody talked about the social networks, which are incredibly important. And I suppose I'll come back to thinking systems, and so thinking individuals and thinking about changing political and economic systems. And one tiny example, a friend and colleague was visiting me from Australia a couple of weeks ago. Terrible floods have happened there. Whole communities washed away, livelihoods gone, etc. You know, whole societies there traumatized. And she and colleagues set up a caravan in a car park for people to come and engage with them. You can say this was an individual intervention. It was very, very open. But really what they were doing We're giving people confidence, giving people direction, putting people in touch with them, and arguably building a population of activists from a population of defeated, fragmented individuals. So I think all these levels are important. They need to come together, and actually there's a science behind how that is done. And so I think there are many, many more fruitful conversations we can have to work at all levels to really push things forward at a maybe more ambitious and transformative level than we've done in public health hitherto.
Yeah, fantastic. Thanks a lot. Unfortunately, we are running out of time here, so I would like to ask you one sentence, key message to the audience to how we take this agenda forward. Only one sentence. Do you want to try again, or shall I? Well, I'll start with Cristiano and then I get to you. Cristiano, one sentence.
I think I believe a key message is every individual contact with a patient in clinical setting counts. And he shouldn't lose the opportunity to act on health promotion through social prescribing and connecting with the social support at the community level.
Fantastic. Yet.
Yeah, I would say let's think in policy terms, in long-term missions. Stop with pilots, but think about how we can work community up step by step by coming closer to the missions. And my mission should be to fight health inequalities, because we might be successful in decreasing the use of tobacco, but we still are not very successful in attacking and fighting health inequalities.
Super.
So a big mission, concrete community of policies, and bridge them.
Good. Yes, Jan.
I fully agree with that, and my point would be, let's make health for all the people a common good that we strive for. Let it make our objective for our societal change processes, and let's hope that we have as many actors as possible that engage in order to achieve that. And I think that this kind of activity and the solidarity that it requires is essential for the future of our society and for the future of Europe.
Yeah, super. Thank you, Susan.
My sentence would be, I think what we really need is collective action for health and also for social change. And it raises two questions: which collectives and what action? And I look forward to the next conversation about that.
Thank you very much. Yes. We come to the end, dear speakers and dear attendants. Thank you very much for your input and your attendance. There are ways from which we can learn from the behavior and cultural science to promote health promotion. Thank you very much for that. Thank you, Caroline.
Yes, and thanks to all speakers, and thanks to Martin for the co-chair. This is definitely something that EuroHealthNet will continue to work on. So you will hear more from us on these topics. Thanks a lot.
Thank you.
And thanks, everyone.